We did a previous session on titanium mesh. Today's session continues on from that and builds up from that. Is what you see on your screen here. It says harvesting from the mandibular ramus. And the title says the harvest. It doesn't talk about the application, but the application would be harvesting from the mandibular ramus to use that as a block graft the way it is, and or another procedure to take that and create a thin bone plate with it, and then use that bone plate much as one would use a matrix band to hold an amalgam in place. So if we wanted to have a complete title on the slide, it would be harvesting, and then its use as a block graft and or its use as a bone plate. Okay, and so it will be all of those. So we'll break it up into 3 basic steps. The first portion of the presentation is going to be on the harvest portion. The second portion will be its use as a block graft. And then the third will be its use as a plate. And is irrespective, the harvest is relevant for both of the 2 applications. I think once you see the 2 applications, you may opt for more often using the plate as opposed to the block. So we'll go through both applications, but you probably want to focus more on the secondary application that we're going to talk about. Okay, this is showing just a little cartoon animation and showing a mid-crestal flap and then out to the buccal. It may be tough to see in a cartoon whether it's buccal or lingual, but it's the buccal. And then is making a cut. The cut in this case is shown with a piezo surgery unit with the saw blade. I find that's really the most efficient way to do it. You know, when I first started out, we were using 701 fissure burrs and it wasted a lot of bone. And then we used bone saws, and they were very thin. They're like a diamond disc. Like the diamond disc dentists use a lot of times to create space between teeth when you need to move the teeth a small amount for ortho. And as diamond disc there was a branded version of it put up by Dentsply, and they had a diamond disc on a straight attachment, the same kind of straight attachment on an implant motor that you would use for a round burr for a sinus lift, for example. And they had half the diamond disc with a shield on it covered so that the portion adjacent soft tissue, you couldn't inadvertently cut the soft tissue there. And they called it a bone saw. So 701 burrs I've used in the past, is diamond discs, is bone saws, and then is the piezo unit. And then you can see in the cartoon was done is it was harvested. You also may have noticed it was cut on the occlusal surface, is on a distal vertical and a mesial vertical. There was no cut at the apical portion. At the apical portion is fractured out. And it could be cut at the apical portion. It's just oftentimes difficult to get access there. The piezo surgery units, they have the straight saw. They do have angle saws at 90-degree angles. And then they would come for a left or a right. And you could get a set of them and use it for the apical portion, the left one for the left, the right one for the right. And in which case you would make an apical cut. But most often, most folks and a lot of units of piezo don't have those. And so with the straight cut, whereas you saw in the little animation there, a chisel and simply fractured at the apex. To control the fracture, one can put a round burr and make a groove at the apical portion from the mesial to the distal verticals, right at the apical portion, so it fractures cleanly is on that line. So the option would be fracture it with a chisel, make a small groove with a round burr, and then fracture the chisel, or have a piezo unit that has a 90-degree is angled saw, and that would have to be a left and a right, depending on which ramus you're going to harvest is it from. And then if we look at this, is in that drawing is there, you see it shows an edentulous area, but that would be about the third molar area. And you could say, well, that's not quite the ramus. No, it can be harvested there, which is really more of what's called the buccal shelf, or it could be harvested is further up, and then would truly be is portion of the ramus. And so it's either one. Is even though we may call it ramus, I find most folks are actually more in the third molar area and really taking more of what would anatomically be is the buccal shelf rather than truly the ascending ramus. Okay, this is a case here. In this particular case, the patient had adequate height, adequate width of bone in the posterior maxilla, inadequate height of bone in the posterior maxilla. So the patient had received a bilateral lateral wall sinus lifts in the posterior. They give them adequate height, and they already had adequate width. In the anterior maxilla, as you see here, is inadequate width and actually adequate height. You can see the flap has been reflected. On your right side on the screen, you see the flap is reflected right up to the nasal floor. And that soft tissue that you see right where the retractor is, that's the soft tissue of the nasal floor. So you can see that's adequate height, but inadequate width. So for the inadequate height in the posterior, it was a sinus lift. For the inadequate width in the anterior, it's going to be grafting. And in this case, it's going to be blocks. So I always would like to measure the size of the defect and harvest a block is accordingly. And you can see on that perio probe, you see the dark black lines, 5 millimeters, the next dark, 10, the next dark, 15, and you can see right of the shank is 20 millimeters. This is not one of the dental perio probes, it's a periosurgery perio probe, because the dental perio probes usually don't go to 20 millimeters. They're usually smaller. So using a surgical perio probe, I'm measuring it. It could also be measured with calipers. And so you see it's 20 millimeters, and we're harvesting a block in this case. In this case, I'm harvesting the block is to use as a block graft. But as I said, we'll talk about the harvest, and then we'll also talk about its applications. It may be tough to see as far as orientation, but I think you can see that one kind of bombed out tooth in the lower left portion of the picture. That's the premolar. So we're distal to the premolar. So this is about the molar areas, first, second, third molars. As I said, it's really not the ascending ramus in this case, more the buccal shelf in that area. And you can see a midcrustal incision as we'd shown in that animation. You can see is a good adequate flap flexion here. And then in this case, I'm putting a chisel in and then chiseling it out. Okay. In this case, I didn't make a groove at the apical portion. If I was concerned that I may or may not be able to get a nice clean break, then I would create a groove, as I mentioned, with a round burr and usually a straight hand piece. Right. And then, and you can see by simply expanding it, and we've got a nice, is a block 20 millimeters long. You can look at the size of that and guesstimate that the height of it is probably about 8 to 10 millimeters. So it's about 20 by 8 to 10 millimeters. But in thickness, it's probably only about 3, is maximum 4 millimeters. We're going to take that out. I'm not showing the pictures, but I like to take a bone file and smooth down the sharp edges. You see in that site that we harvested from, there's some sharp edges. So I take a bone file and smooth those out so there's no irritation to the soft tissues. And then the second thing I do to minimize the irritation of soft tissues is I fill that defect in. Even though it doesn't have a lot of walls, there's no buccal wall, there's a lingual wall to be sure, small mesial wall, small distal wall, small apical wall. So it's kind of a 4-wall defect, but not a very deep 4-wall defect. So it's tough to get containment. So I can't put particulate in there. This has to be in a putty configuration. So this has to be the sticky bone. And what I like to use is using tissue bank bone particulate. I take the tissue bank bone particulate. Of course, I use the Osteolife tissue bank. It's made at the University of Miami. Dr. Ted Malinin has been processing there and been the director of the tissue bank. Is an orthopedic surgeon by training and has been there for over 40 years, is directing that, and is considered the premier tissue bank in the country. So I take that particulate, hydrate it, spin the PRP in what is called the red top test tube in the US. That's a test tube that has nothing in it. It is only glass. The glass causes clotting. And so I spin it for 3 minutes. 3 minutes isn't adequate time for it to clot. So just starting the clot. get the middle layer, which is a concentrated platelets, concentrated fibrin, and concentrated white blood cells. And then hydrate the particulate is with that middle layer, and then let it sit for about 10 minutes. And while it sits, the coagulation happens of that middle layer of those concentrated platelets and fibrin and white blood cells. And as they clot around the particulate, it takes on the consistency of a gummy bear. And that's why I oftentimes refer to it as sticky bone, then oftentimes refer to it as gummy bone, because it has consistency of a gummy bear candy. And I'll show you that in an upcoming slide, where you can literally pick it up like a child would pick up a gummy bear candy and put it in their mouth. And you can pick it up with some fingers or pick it up with tweezers. It doesn't fall apart and has that type of consistency. So we've got to put some type of a consistency like that, not particulate hydrated with saline, because it would wash out too easily. So a gummy bone consistency, some type of commercial putty that's made with gelatin in there, that would be fine. I don't like the gelatin base because it takes up some volume that otherwise would have been bone or PRP. And there's a number of other products. Some have carboxymethylcellulose. Again, that takes up some of the volume that would otherwise be bone or PRP. Whereas if I have just particular bone and PRP, it's 100% bone and PRP, not 20, 30, 40% of it as gelatin, or 20, 30, 40% of it as carboxymethylcellulose. So that's the preferred one. But whatever configuration you choose to use, it's got to be a putty configuration. I take that block, that's live viable cells. In this case, rather than trying to bend the block around the arch and creating a V in it for that nasal spine that's there, and or trimming down the nasal spine, those are all options. What I simply did is cut the block in two pieces. And I'm putting one to the right side of the nasal spine and one to the left side of the nasal spine. And then drilling 2 holes in it. The holes can be drilled on the back table or in the mouth. I find it much easier to drill on the back table rather than trying to hold it in the mouth and drill all at the same time. The back table works a lot easier for me. And so is putting this in, and then is fixating it. Whenever possible, sometimes a block is so small, I've got to fixate it with 1 screw. But whenever possible, I'd like a minimum of 2 screws. And what happens with 1 screw, you can still have rotation of the block. It may wedge in there because you might have made a good inlay prep. It may not be complete smooth, so it may wedge in there with just 1 screw. But with 2 screws, I can be absolutely sure it's not going to spin around. So I always prefer 2 screws whenever possible. If it's a very, very small block and there's a danger that I may crack the block in order to get a second screw in there, then I may opt to put a 1 screw in. But in those cases, I am always sure to make more of an inlay prep when I reflect the flap to minimize the chance of it rotating. We had talked in the previous session about making the flap here and presuming everyone is going through each of the sessions, but just a quick review if someone has come to this session didn't take the previous session. The flap that's made here, I've got to be sure there's no soft tissue there, because if I had soft tissue there and I put the graft over it, I have host bone, soft tissue, graft bone. The cells from the host bone can't migrate through as efficiently with that soft tissue there, that baby and grandbaby bone cells in the block graft. And so it will delay and or even affect it. What I don't get is bone growth there. So I've got to be sure the soft tissue has been taken off of it. And that's done with a sharp periosteal elevator. If they dull over time, you got to sharpen them. It's done by scraping that bone, that host bone there, with a brand new scalpel blade. It's done by running a burr over that host bone and irrigating well with saline to get rid of any tissue tags there. And so I've gone over quickly the concepts we described in the previous module, but we've got to be sure that all that's been removed. In this case, I fixate. It's always important to minimize opening of soft tissues. And so here what you see me doing on your right is rounding the corners of that block graft. All right. And if I've got it well stabilized with 2 screws, as we do here, I can round it and it's not going to affect the stability of it. So we've got to stabilize. I'm rounding the edges. We're going to further round the edges by placing particulate bone around it. And that can be hydrated with PRP liquid, or the putty configuration is either one. In the recipient site, the donor site where harvested the Ramus from, it has to be the putty configuration in this defect. Here in the recipient site, it could be putty or simply hydrated PRP as a particulate, but we put that in. So we'll go to a quick surgery here. This is not in real time, of course, because this is about a 5-minute video and the surgery is actually 50 minutes, so it's trimmed down just to some of the pertinent things. Flap is mid-crustal or slightly palatal. Around the necks of the teeth, okay, is 1 or 2 teeth over, in this case just 1 tooth over, is taking the sharp pointy side of the periosteal elevator to begin the reflection, the wider side, and then is reflecting a flap in the posterior mandible, similar to what would be done for third molar removal, an impacted third molar. And then in this case, cutting with our piezo unit. It's hard to see here because the piezo unit's covering the angle, but I can tell you this is the crustal portion. All right. And then after we get the crustal portion cut, we'll cut the vertical on the meso and distal. In this case, I'm going to do it with the same saw blade is there. But as I mentioned, companies make different angle saw blades. They've got 90-degree angles to get at the apex. They've also got angulations to make it easier to get at the meso or distal cuts. I'm just going to turn the handpiece and make the meso and distal cuts here. Okay, you see, I'm just turning the handpiece by 90 degrees, okay, and making the distal cut. All right. For those who haven't used a piezo before and used is electric motors, you'll see that this works very, very fine, nice fine cut. And it's very atraumatic in the sense that if I inadvertently hit soft tissue, it doesn't cut it. On the downside is it's slow, and you may have noticed that already. It's much, much slower than handpieces, okay? So I use in cases where the benefits outweigh the negatives, where safety concerns is. Now, in this case, I'm well buccal to the inferior nerve. And so even if it was this high, I wouldn't need to be concerned about it. And you could check that with the CT scan, of course. But if you want to be extra safe, you would just confirm on a CT scan of Panorex that you're going to stay not just buccal to it, but occlusal to it, coronal to it. And so you'd measure how much bone you've got coronal to the inferior nerve, stay well coronal to that, and stay out of harm's way. Is the inferior nerve back here, it enters on the lingual side. Sometimes it crosses straight overs on the buccal very quickly. Sometimes it meanders on the lingual and then cuts over the buccal to exit the mental foramen, and sometimes kind of goes halfway is down. All right. In this case, we put a chisel in, and you can see I'm just gently rocking that out. You can put a mallet on it to tap on it. You see here, I don't need to, and in fact, most often, I don't need to. Okay. So there we've got our harvest. Okay, we're going to then put our gummy bone in there is after we smooth the edges with a bone file, all right, and then suture that up. All right, for suture there, I use the polylactic acid suture like the Ethicon is a Vicryl suture. I actually like the Violet brand of it from Osteolife, but made of the same material. Okay, and that's what that is. That's the 3.0 is Violet suture. Has about a 3-week resorption time. Is we'll let it resorb out on its own. But we'll get the patient back in to check them at 10 days. And if everything's healing well, we'll go ahead and take it out then. Otherwise, let it just come out on its own. Okay, so we had smoothed that down in there with a bone file. We had put our gummy bone in there, and then we sutured it up. In this particular case, I'm actually taking down the nasal spine a bit. Okay, the case I showed you with slides, I was previous to this, a different case. I left it In this case, I'm smoothing it down. You can see what I'm doing is by is I made the flap, sharp parallel to the elevator, but then I'm either going to scrape with a sharp blade, or in this case, go over it with a burr. That makes sure I get rid of any tissue tags there. And as we rinse and grind a little bit, you can begin to see some soft tissue there, especially where tooth number 8 was, upper right central. You see where we are now, a few tissue tags there. Okay. And so you see what this does is it gets rid of all of that, gets rid of a small layer of a bone there as well, but it's getting rid of all that. So I'll make sure that I've got host bone to bone graft, not host bone, a layer of soft tissue to delay or prevent healing. And I've seen that's the biggest mistake folks make in bone grafting is leaving a layer of soft tissue and then wondering why the graft didn't work. Okay. Here we are is in this case making the holes in the back table. Okay. Is and then once I've made the holes in the back table, I hold it in place in the mouth and use that almost like my guide, right? To make the holes in the recipient site. So that bone block was used as a guide to make the holes in the recipient site and then screw fixated in. What you'll see is that the screw slid right through the block because what I'm doing is I'm making the hole in the block large enough that it's not engaging the block, it's sliding through, but engaging the host bone. Right? And then what you see here is with the burr, we smoothed out the sharp corners of that bone block to minimize any chance of soft tissue dehiscence. Particular graft, in this case, again, tissue bank is the osteolyte freeze-dried bone, is hydrated with PRP. In this case, not the gummy bone configuration. In the donor site here was a gummy bone configuration. Here it just is hydrated with liquid PRP. And then our PRP membranes on top. And they're going to help both the bone heal is because they've got the growth factors in them. And they're going to help the soft tissue heal is that's overlying them. Okay. And then we're sutured up. Okay. Now, here's the thing, is when I've got a block graft, as we just showed here, and this I discussed in the previous module, but I'll go through this quickly just to refresh. What you see on the left-hand side, that block graft, the blood vessels coming from the host bone that try to grow into it to provide vascularity to it and to provide the bone-forming cells, which are the lining of those blood vessels, is they can't invaginate. What it says, that vessels are unable to penetrate. Is whereas if that was particulate here, they could invaginate very quickly and grow in between the particles. The problem was if I had too much particulate here, it would have been hard to stabilize it with those PRP membranes there. Right? So with the block, I've got good mechanical stability. That's the big advantage. With particulate, it's harder to get the stability. Okay, we'll figure out other ways to get stability even with particulate, but for now is historically for stability we use blocks. Okay, but blocks does give us slower healing, and it heals from the ridge out to the soft tissue, and so the outer layer takes the longest is to heal out there. So we could say, well, if the block is going to take longer, is there a way to use particulate there? All right, and we could use the same harvest. Once again, you see a premolar there. We're going distal to that, and we're in fact going to graft in that same site. If we need height and width in those molar sites that are missing, and now the donor site is in the same area, the same vicinity as the recipient site. So we'll make our incision. In this case, I'm making 2 incisions. First, a split thickness incision for just the mucosa, and then a separate incision for the muscle and the periosteum. And so then we can close it in layers and then close the muscle and periosteum layer and then close the mucosa layer. So if one layer were to come loose, I've still got a second layer closed. So we're going to do layered closure. And or if I wanted to leave one the muscle and periosteal layer closed and leave the mucosal layer is open, it is even to granulate in, I wouldn't be a denuded bone there. And so a layered is incision. That's the top layer. And then what you see here is the second layer is now we're down to bone. All right. And once we're down to bone is we're going to reflect the flap posteriorly. Okay. And then start harvesting our bone. Now, what you'll notice here, you'll say, wait a minute, this block is not nearly as thick as the previous two cases where we were doing block grafts. I mean, that's not going to give a lot of width at all. That's intentional. It's a very thin block. You see 1 millimeter is maybe 2 millimeters at best, 1 millimeter. That was intentional. We're not going to use a block graft. We'll use it as a matrix band. We'll use it as a bone plate as opposed to a bone block. All right. So we're harvesting that. Okay. Now we'll go harvest another piece because it's so thin. You see on the left-hand side, just 1 or 2 millimeters. Okay. We'll take another 3 millimeters. Now this one will be more like a block. All right. So that looks more like the block that I showed in previous cases. So now I took one plate and one block instead of just a block. All right. And so we've got both of those. All right. And then, as you know, is the crustal cut, is the mesial cut, distal cut, apical, either a cut with a piezo or round burr groove or chiseled out. In this case, it was simply chiseled out. And I've got my block. All right. So what you see in the right-hand side of your screen is you see first the thin plate, that's on the left side. Then you see on the right side the block. That's got a bit more cortical bone and the cancellous portion of that block. All right. Now, what we could do is we could take that block, and you can see it on the upper right screen. You see there's cancellous bone. You see that's a reddish portion. And we can take a bone scraper, which you see on the left-hand side, sort of a bone shaver, and shave all of the cancellous bone out of it. And if you shave all the cancellous bone out of it, and even shave some of the cortical bone until we take that 3 millimeter block and thin it down to 1 millimeter, we've actually converted that block into a plate. And that's what we're doing. We're converting that block into a plate. Okay? That scraper is called an MX grafter. The name of the company that manufactures it, you can see it's Maxillon Laboratories, is from New Hampshire. The company was started by an engineer and an oral maxillofacial surgeon. And this is pretty much the only product that they have. It's sort of a one product company. And they don't sell it direct because the oral surgeon doesn't have time to sell it from his office. They sell it through distributors and a number of different companies. I just simply get it from Osteolife Biomedical because they're one of the distributors. And since I'm getting this freeze-dried bone from them. And so what you see there in that box, it comes is in sterile packing. You peel the packing back, and inside is this sterile instrument, this MX grafter. If you look on your lower left, you see the tip of it. It's a curved blade. And from what they've explained to me, it's because that curve, it concentrates the forces right at the point that ends up hitting the bone. And by concentrating the forces right there, is it ends up as being able to actually cut bone. Is because otherwise you think, wow, cutting bone, even cancellous would be tough, and certainly cortical would be impossible. And no, it's absolutely possible. It works very, very efficiently, in fact. Is you flip it over, and what you see on your lower right portion of your screen is a clear chamber. That's where the bone goes. So it is not like a Gracie curette flicking off is calculus, where it just flicks anywhere. Here, everything goes in that container. And the second thing is the movement is not like a Gracie curette trying to flick things off. It's sliding. It's a gliding motion. And the MX grafter held that 20 to 30 degrees off the bone and simply sliding motion off of it. You also see in that clear chamber is a little groove. That's for 0.5 cc's. The next little notch there is for 1 cc. My fingers are covering up the next notch, but that's at 1.5 cc's. And the container then goes on to 2 cc's. So the tip portion of that clear chamber holds 0.5. The next portion right up to my index fingertip is 1 cc. Is beyond my finger, you see that little line there, that's 1.5. And beyond what's out of the screen is 2 cc's. Okay, so it holds up to 2 cc's. And I'm showing it demonstrating on a dry skull specimen is simply harvesting is from the ramus is externally. But in this case, we'll harvest from the inside of that block. And this is what you get, is that these types of curlicue ribbons, is that this ribbon configuration. And what happens when you get that ribbon configuration is it does a couple of nice things. One, it allows for this shaving, allows for the cut. But when it's in ribbon configuration, is studies show you have more exposure of more bone morphogenic proteins, more BMPs. So BMPs are then more exposed than if it wasn't in this ribbon configuration. The other advantage when you get a ribbon configuration like this, it helps hold it together better. See, the ribbon configuration is, even if you mix it with PRP, it holds well together. Even with saline, it would help hold it together. Certainly as gummy bone, it holds together phenomenally. So ribbon configuration helps in both of those aspects. More BMPs and better is holding together. Now, that was just shown under a microscope. Clinically, this is how it would look. Okay, and clinically, this is shown is from the external oblique angle, is harvested. You see on the lower right, as you see, even with just the local blood there without PRP, I think you can imagine how well it's holding together. By harvesting like this, there's no drilling, so no contamination from is that. There's no high temperature, there's none of that. Is when folks talk about using drill bits of any type, reverse cutting drill bits or drill bits with containers on them and such, there's still temperature there, still concern about maybe killing some bone cells. Here is zero of that. And then looking at the quality of this clinically, as my colleague Michael Pellig at the university and myself, we published this in the Journal of Oral Maxillofacial Surgery back in 2004. That was 16 years ago. We've been using this longer than that, because clearly we did this study back in 2003, 2002. So we've been using this MX grafter for nearly 20 years successfully. Still around, still hasn't needed any modifications. I've still never seen any of the clones or the copycats or imitators of it do nearly as good of a job of it. And so I would tell you, for this product, stick with the name brand rather than the imitators. When a clone product works just as well, I'm happy to use it. But in this case, the name brand. And Michael Pellig, myself, you can see it's Craig Mish, Ziv Mazor, we published on this. And what we were looking at is to determine whether this type of bone is, because a lot of times, if you're not taking it from the inside of this block, like we're going to do in these upcoming cases, if you're simply taking from ramus, a lot of it might be cortical bone. Whereas if I take bone from the tibia, that's good cancellous bone marrow. And we thought, well, this cortical bone that's taken as shavings from the ramus or shaving from the tuberosity, it can't be as good as good tibia bone. So we did a research project and said, let's do bilateral defects. One side of the ridge with his tibia bone, one side with his bone shaving bone, or bilateral sinus lifts, lateral wall, one side with tibia bone, one side with bone shaving bone. What we found is, and we published in this 2004 study, is they work just as well. Is the maxillary sinus and ridge augmentation using surface-derived autogenous bone. The journal made us change the word. Instead of bone scrapings, they made us use a fancy word, is surface-derived, but it means this bone scraping from the MX grafter, as it works just as well. So the quality of this bone is excellent, when it's done like this. And because of curved blade, because of the configuration, ribbon configuration, is because of the low heat, is because of low contamination. And so it's become a huge part of my clinical practice of harvesting when I need these kinds of volumes, 1.5, 1.5, 2 cc's is using this. So now, as you'll see on the right-hand side, on the left-hand side, you'll see the bone plate we harvested. Can we harvest one bone plate? Is me just trying it in for bone height. Is on the mesial aspect, I've got it stabilized on the portion of the ridge. On the distal aspect, I've got it stabilized. And then you can see the ridges like a U shape. In that U shape is where we're going to graft to get additional height. And of course, we need additional width. I'll make a second bone plate, and you can see it on the right-hand side. And you can see what I've done is to grip that. I've gripped that bone block with a hemostat. I've taken the cover that fits on that box that makes the PRP membranes, and the lid of it has that groove that inside there to fit over that PRP box. Okay, I put that hemostat up against it. Okay, so the whole thing's not moving as I'm pulling. Okay, so the block doesn't move and the hemostat doesn't move. So it stabilizes both the block and the hemostat exactly. All right, if my friend Pavel's looking at this, maybe he can come up with a better device is to be able to stabilize this. But this is what I'm using. Stabilizes it is the block is stabilized with the hemostat is stabilized in that groove, and then I'm scraping. All right, and now what I've done is I've got 2 plates. The first plate, because we harvested a thin plate. The second plate, we created a plate because we thinned out the block and created a plate. All right, and what you can see is on the right-hand side, the amount of bone that we obtained from thinning the plate. All right, it's a fair amount. And what happens is the amount you imagine that's in the block, it expands. When it gets fluffy like this, okay, the loose and fluffy, it expands. If you think about it, if you've ever planted a tree in the backyard, you dig a hole, and then you has got all the dirt. You put that, the tree roots in there, and then you start putting the dirt in, and you get too much dirt. You got to mount it up around the tree. You got extra dirt, right? Because what happens when it's in the ground is packed down hard, and you dug it out, it got fluffy, right? So now it always feels like it's got too much dirt. The same concept is happening with the bone. When you scraped it, it got fluffier. So even though that's not particular from a bottle or from a tissue bank, that is not any additional harvesting that I did that I snuck in and didn't show you the pictures. That is literally just the harvesting from the bone shavings from that one block. Okay, and you can see it's going to be enough. It's going to be too much bone. The 2 plates I've got now, one that we harvested a thin plate, the second we created by thinning the block. I round the corners, as you can see in the upper right-hand portion of your screen. Right, I round the edges. I've drilled the 2 holes like I like to do on the back table. And then we're going to take that to our site. Right, I would have estimated where I needed to drill the holes in the mouth, and then take it to the back table to create the holes. We'll put it back in. We're going to put that on what would be the occlusal surface. All right, and then once I'm holding in place, as I mentioned before, I'm always going to use that with the holes in it as my template for where to drill the holes for the screw. So I'll drill the holes for the screw. Now, as you can see here, when I use a screw fixation kit, you see on the left-hand side, the head of the screw is above the bone. Whereas on the right-hand side, it fits within the bone, right? And so I always prefer the right-hand side. The left-hand side, you see that little starburst there that's there, it can cause rough edges. And so I prefer a screw head, not that's boxed and is going to sit above the blocks, that's tapered and wedges into the block or into the plate, okay? So that I don't have the sharp edges sticking up, okay? And then the screw fixation is, I'd like to have a variety of lengths and a variety of diameters. And so you can see here in this kit, this is the kit that I use is for implant vision. You can see the lengths are 3 millimeters, 4 millimeters, 6 millimeters, 8 millimeters, 10 millimeters, 12 millimeters. Well, the 3 and 4 millimeters I use for holding in things like titanium mesh or membranes. For blocks or plates, I use the 6, 8, 10, and 12. So you see listed here 6, 8, 10, and 12 is on the text. That's what I'm using for plates and blocks. But the kit actually has 3s and 4s that I can use for titanium meshes and membranes. All right. And in this particular kit, it actually comes with titanium meshes, you can see in the lower right-hand compartment. All right. It also comes with bone tacks. And you can see there's 3 millimeter and 5 millimeter bone tacks. All right. So I could tack in the membranes. So I've got everything that I need. I can use tacks of either 3 or 5 millimeters is to tack in membrane or titanium mesh. I can screw them in with 3 or 4 millimeter screws. I can use 6, 8, 10, and 12 millimeter screws for bone plates or for as bone blocks or as tinting screws. They also come in different diameters, is 1.4 You see the diameter listed on the box there, 1.6, 2.0, right? Different diameters, right? What I like about this particular kit is the lens are color-coded. And I've used screw fixation kits for years, for decades, and they've always just been stainless steel color. And it's hard to figure out what size is which. All right? And especially the assistant puts a wrong size screw in the wrong hole. Here, it's all color-coded. The gold are 3s, and the blues are 4s, and the greens are 6, and the lavender are 8, and the light blue is 10, and the aqua blue is 12. So I can look at it, I can tell that, yes, I have the correct size. So it's the only kit that I know of that has color coding. Now we've got different diameters, 1.4, 1.6, 2.0. For a 1.6 screw, if you drill the 1.6 hole in the underlying bone, the screw would slip in and out. So the hole has to be smaller in diameter, right? Because it's going to tap its own way in. So you also see in the kit, right kind of in the center of the box, there's 3 different drill bits. It's 3 different drill bits for 3 different diameter screws. So you got to be sure you pick up the right drill bit for the right screw. All right. And so if it's the 1.4 screw, I would use the drill bit for that, which is not 1.4. It'll probably be about a 1.2. If I'm going to use the 1.6 is a screw, it's not a 1.6 drill bit, it'll be about a 1.4 drill bit, so that it actually has to engage on the way in. If it's a 2.0 screw, it's not going to be 2.0 drill bit, it'll be a 1.8 drill bit. So it's got to screw its way in. So just be sure you use the right drill bit for the right screw is there. And so now we're using the right drill bit for the screw. Okay, I'm using the 1.6s. Okay, you can tell the lavender color is 8 millimeters. That's 8 millimeter screw. Okay, and I'm putting that in. All right, that's on the distal aspect. On the mesial aspect, it's another lavender. It's a 1.6 diameter. You can tell it's another 8 millimeters in length. Okay, so you can tell is in above the crest of bone and holding that plate in, probably about 3 millimeters of the screw, 4 millimeters of the screw is above it. So you can tell I've got at least 4 millimeters, probably 5 millimeters of screw engaging the host bone. So 4 to 5 millimeters engaging the host bone, and that's usually the minimum amount I need. Okay, and about 3 millimeters above. All right, and now that I've got that fixated, now I'm trying in my second bone plate. You can see that in the lower right-hand side is the occlusal plate is already screwed in. The buccal plate, I'm just trying it in so I can get an idea of where I need to make the screw holes, where I need to put the screws. So now I'm going to have a good container, right, to hold the bone. The bone is going to be held on a lingual from the lingual soft tissue. The buccal with that buccal bone plate, occlusal with that occlusal bone plate, okay, on the inferior by the mandible itself. Okay, on the distal and mesial by the mandible itself. So mesial and distal by the mandible itself, right, is at the bottom by the mandible itself, on the top by the bone plate, on the buccal of the bone plate, on the lingual by the soft tissue, right? And then you can see I've taken my PRP gel, I've put them into that box, and they're going to get compressed into PRP membranes. Okay, and as I told you, I did a 3-minute spin of the PRP. Got the middle layer before it is clotted, hydrated my bone. In this case, this was autologous bone, the patient's own bone, is from the scrapings on the inside of that block and literally it's like a gummy bear candy. As I told you, you can pick up with your fingers. You can, try to bend it. Has a gummy bone, gummy bear consistency. I call it gummy bone or sticky bone. All right, I take that. And now I can take it to the recipient site. There's a recipient site. You can see we've got the bone plate on top. I'm taking this gummy bear bone, sliding it in there, and you can see only about half of it fits. Okay, as much as it would have seemed like it wouldn't have been enough bone just harvested from that block, it is actually more than enough. Okay, I'm actually I'll get it to fit because I get all the nooks and crannies but you see, it's filled the area completely and then some. All right, and then I take little bone condensers and work it in all the nooks and crannies. All right, now this is a mirror shot, and so it looks like, wait a minute, did he go to the other side of the of the arch. No, it's the same side of the arch, but it's bouncing off the mirror. So now you see on your left side, you can see that is completely full, is from top to bottom and all the way out to the buccal. And we're going all the way lingual, all the way mesial, all the way distal, all the way out to the buccal. Right? And you can see it on the right hand one as well. Again, those are mirror shots, so it may be disorienting as to which side of the mandible we're on. And now then I take the other plate that I have and put on the buccal. Again, this is a mirror shot, so maybe tough to orient yourself for which side it is. But what I want you to see is I used once again is 1 8mm and then 1 6mm screw in this case. Okay, is screw fixated is in this case I did 6mm because the plate is thin. Still got 5mm within my host bone. Right? And now complete containment is all in autogenous bone is there. Right? Then I put a little bit is over the top. That's not really to form a lot of bone because the bone forming cells are going to come from the underlying bone. Right? So the underlying bone, I had decorticated a bit. You didn't see in the slide, but I decorticated to allow the bone forming cells and blood vessels to come is from within. And they're not going to then migrate through these cortical bone plates. So this on top really isn't going to grow is any significant amount of bone at all. This is more just around the edges. Because around the edges of the bone plates, around the edges, but in case, if I'm putting that screw in at 90 degrees, it will actually wedge it. If it's not at 90 degrees of the bone plate, a corner will still stick up. And so if you see a corner sticking up, it's because not at 90 degrees, right? It's designed to go straight at 90 degrees, it will be flush, right? And so it'll be countersunk. And so it's a round out rough edges on a screw, rough edges on the block is some point. So that could actually be part of my autogenous bone I had from the scrapings, or that could actually be tissue bank bone is there. All right. And then closed in 2 layers. Again, see the mirror shots. So it's a little bit disorienting which side of the mandible it is, but is layered closure. And so even if one layer opens, the second layer is there. And here I'm using a non-resorbable suture, the Gore-Tex sutures. I'm using those so I can control exactly when this is going to be removed. I don't want a resorbable suture in this case because if things open up too prematurely, we end up losing these types of grafts. So, and I usually take these out not at 10 days, but at about 6 weeks. So I make sure everything's closed, and not just closed, that there's strong tensile strength there, to not just be closed, but to maintain the closure even if we remove the sutures there. So we'll go through another case, okay, and then we'll start wrapping up the session, okay. Here's another case. In this case, the centrals are missing. The laterals had a definitive bridge on them, I guess, and over time the patient has periodontal disease. So we're going to extract the teeth, do socket preservations in the sockets, and then bone plates where the central incisors were, okay. So our incisions. All right, reflecting our flap, and then making sure it's a good full thickness is flap, and then I'm extracting the teeth. I like these forceps that tell my assistants exactly what tooth numbers are for. It's the American system, so we've got international folks tuning in. It wouldn't work there, but it says on the tooth number 6, 7, 8, 9, 10, 11. So if I'm extracting tooth number 7 and 10, she knows which forcep to get. Get the one that says number 7 and number 10 on it, okay? Without having her need to remember, it should be a 1 or 99, which forcep number is it? And so I like the kids to have numbers of which tooth is for. For example, upper molar she doesn't have to remember it. Should it be an 88R and 88L? It should simply say 2, 3, or 14, 15. Again, with the American numbering system is what I'm using. And then international folks could get the same thing with the international numbering system on it. And then you see now the teeth have been extracted. We'll clean that out with a piezo, a diamond burr, flush everything out nicely so we don't have infections there. We'll have to advance the flap to get over primary closure over the extraction sockets. We've made an incision, in this case, not quite like a third molar, instead of intercircular around the necks of those mandibular teeth. I simply made it out in the vestibule, so vestibular incision, and then exposed the lateral wall of the mandible, is that buccal shelf area, and then make our piezo cuts. I made the piezo cuts, okay? And then we'll take that block. In this case, just one plate we're going to create, not two plates. We're taking one block, and from that one block, crustal cut, mesial-distal, fractured at the apical portion. We'll take that, and then once again, hold it with my hemostats. That holds the block. The groove in that box there holds my hemostat, and then start scraping. And it doesn't seem like, wow, am I really going to get enough bone off of just one block like that to fill in all of this area, including the sockets? Yes, it actually does. Look at that. Okay, that's all from that same block. Okay, and you remember we said 0.5, 1, 1.52 cc's? Okay, that's beyond 1.5 cc's. That's almost 2 cc's of bone. Okay, is when you buy a bottle of 1 cc, another, that's like 2 bottles of 1 cc's bone. Okay, all from that. Okay, and then we take that. Is now what you see on the left hand side is that's the plate that I've created from the block by thinning out the block, creating a plate. What you see on the right hand side is the powder that we created. Okay, almost 2 cc's of bone shavings. Okay, giving it nice consistency to expose more BMPs. Nice consistency so it locks together, holds together better. Okay. And here just with some saline, we wick off the saline, and you can see in the upper right how much bone we've got. Okay, is plenty for this defect. Okay, whereas when you saw that block initially, it may have looked like it wouldn't be enough. Okay, there's the plate on the upper left. Okay, I could actually thin that a bit more. I really don't need it that strong or that thick. I could thin it a bit more and actually harvest some more. I felt this was enough harvest and we didn't thin it anymore. But if I needed more, I would have just kept on thinning it. Okay, there's some more. Now I've hydrated with the PRP. And you see that picture on the right-hand side is hydrated with the PRP. We'll take that block, is the sockets. The socket walls will be the container for the graft material. But where the central incisors were, the bone plate will be the one. In this case, I create a little notch just to fit around that nasal spine there. You see that on the upper right side. Okay, I could have ground down the nasal spine as well, but I just left it there and create a notch to fit around there. Okay, created the 2 holes. Again, I like to do on the back table, is then use the holes in the bone plate as my template and then as my guide, so to speak, and drill the holes for the recipient site. The purple, the 8 millimeter, 1.6 millimeters in diameter. I'm going to have at least 5-6 millimeters engagement in bone, and then is about 3 millimeters or 4 millimeters sticking up. Okay, that's the first screw. And on the left side is tightened down. On the right side, it wasn't quite tightened down yet. Okay, that's the next screw. On this side, there's minimal buccal plate, and it's not just the bone. I'm going through the extraction socket itself. So I'm actually using the 12 millimeter screw, and you'll see why in a minute. You see why on that extraction socket, the patient's upper left lateral incisor, I'm using the 12 millimeter screw because the screw has to go into the palatal bone, cover the extraction socket, and engage the plate. Okay, so I'm able to do all of that. So on the left side, on the patient's right side, is upper right central, 8 millimeter screw. It's engaging the bone. Is on the buccal and then the palatal. On the patient's left side, it's engaging the thin plate of the extraction socket. Really, mainly is the palatal aspect. Okay, and now I fill it all up. Okay, I fill all of that up. The sockets, both sockets, and both missing teeth here. And now you can see the size of that. If you compare it over to the ridge on the far left, it sticks out beyond the host ridge. If you look at the ridge just right around the canine area, it extends beyond that. And so we're going to plenty of adequate bone in order to do our implants there. And so there we've got that. As we've taken our PRP gel, placed in the box, compressed them, made our PRP membranes. We're going to put the PRP membranes down. That's going to help for the bone maturation as well as the soft tissue maturation. Okay, and then we close this up. Okay, all right. So I wanted to go through this in terms of how to do the harvest. Right, is how to use as a block. and how to use it as a plate. And I think is, as far as from a healing perspective, is when that slide, the drawing I showed you, block versus the plate and particulate. You can imagine which are going to heal better and faster will be the plates and particulate as opposed to the block. And the amount of work effort is nearly the same. Either way, you got to harvest a ramus. With the plate, you got to do some thinning, but there's a nice, easy way with that MX grafter. Is the only time you may have to use blocks, I've seen that the plate may or may not be able to be mechanically fixated there. Okay, but a great technique is for about 1 tooth, 2 teeth, maybe 3 teeth is 1, 2, or 3 teeth. Right? Longer than that spans, we'd have to look at something else. Okay, we'd have to look at either titanium mesh, because that comes, as you saw in the box, is unlimited supply, or tissue bank plates. And that will be our next module. We'll talk about tissue bank plates. Okay, for this one, thank you, everyone.